My name's Caroline Miller and I'm the chair today. The topic today is the University of Adelaide on public health, and we have two excellent speakers. We have Dr. Rhiannon Pilkington and we have Professor Zoe Jordan. Firstly, I'd like to start by acknowledging the traditional owners of the land. I acknowledge and respect the traditional custodians whose ancestral lands we're meeting on here today. And for me, and I'm sure for many of us, it's the Kaurna people. I acknowledge the deep feelings of attachment and relationship of the Kaurna people to their place. I also pay respects to the cultural authority of Aboriginal and Torres Strait Islander people visiting from other areas or joining from other areas present here today. A little bit of housekeeping. Please type your questions into the Q&A section of your Zoom window and then I'll put those questions to the speaker. The session today is being recorded and will be available to you later on the ABMC website. So now I'd like to pass over to our first speaker. So our first speaker is Rhiannon Pilkington. Rhiannon is an epidemiologist in the Better Start research group in the School of Public Health. She works with government and non-government organisations in SA, Victoria and New South Wales, using their data to bring a public health perspective to service design and delivery to achieve better outcomes for populations experiencing different forms of disadvantage. So over to you, thank you.
Thanks so much, Caroline, for the introduction. I too would like to acknowledge that I live, work, and today I'm presenting on the lands of the Kaurna people, and I'd like to acknowledge and pay my respects to Kaurna elders past, present and emerging. So as Caroline mentioned, I'm in the Better Start Child Health and Development Research Group in the School of Public Health. We're an interdisciplinary bunch, but if you want to know more about us, there's a couple of links there you can visit. So although we are interdisciplinary, we all have a common interest in that we are all in research to understand how we can break cycles of intergenerational disadvantage. So this might be a familiar story to many of you, but of course we see many adults out in our communities experiencing different types of social and health disadvantage. And then we see this get transmitted to their children in different ways. And of course this manifests over different stages of the life course. And then we see that often eventuate into labour market and income disadvantage. And then we have another adult experiencing various types of social and health disadvantage later in life. So what we're really interested in is asking, what can we actually do across these life stages to support children born into adverse circumstances? Now, one of the key, I suppose, platforms for all of the research we do in that space is the BBOLD platform. So BBOLD stands for Better Evidence, Better Outcomes Linked Data. And this is really the core of which most of our research comes from. So this is a de-identified linked administrative data platform. So it includes data across health, social, welfare and justice sectors in South Australia. And we've also got federal data from the Department for Social Services in Centrelink and also the Australian Early Development Census. So we've got about 500,000 children in this data platform. We can group those children into families and see information on their mothers and their fathers as identified in birth registrations. And there are about 18,000 Aboriginal Torres Strait Islander children and about 75 to 100,000 culturally and linguistically diverse children, depending on how you define that. So we use this data in many different ways, but one of the things we've been recently, I suppose, well, we've been talking about it for a long time with Dr. Odette Pearson at SAMRI and Wardley Paringa, but we've recently been working with Odette and ACRA, who are the Aboriginal Communities and Families Research Alliance, really around how can we operationalise Indigenous data sovereignty principles in terms of the use of this data for Aboriginal Torres Strait Islander communities. So we've written a bit about how we use this data platform, and there's some examples in there of various types of analysis we've done with our government partners. So you can go and have a look at that chapter if you want to know more. So back to the idea of how we use this linked data. I guess, so I'm an epidemiologist, so I think about how we use data to tell stories. And Miguel Hernan and a couple of colleagues from Harvard have given us a really nice framework of how we can think about that. So they talk about descriptive epidemiology. So for us, that means profiling populations of interest when we think about how we better support children and families in our community. We think about prediction. So can we use formal risk prediction methods to understand who's at risk? And then we also think about and deploy causal inference methods. So that really comes down to this idea of what actually works to improve outcomes amongst these populations we're interested in. Of course, today's a really short presentation, so I'm going to whiz through a couple of quick examples looking at descriptive epidemiology and causal inference. So that first example I'm going to look at is actually around child protection as a public health problem. So we do a lot of research understanding child abuse and neglect and contact with the child protection system in South Australia. And this is just one example of that research. And we're looking at children born 2003 to 2007, and we're following all of those children until they age 10. So there's about 20,000 births in each of those cohorts on average. And what we see if we look at their child protection experience is just under 1 in 3 children in South Australia will be notified to the Department for Child Protection with an allegation of abuse or neglect by age 10. Now, if we step through the system, we see that just 1 in 5 or 20%, that notification will be screened in. So that means the department's determined this is a child protection matter and it needs to be investigated further. Now, 1 in 10 of those children will have an allegation of abuse or neglect formally investigated by the department by age 10. And then we see 1 in 20 having a substantiated notification of abuse or neglect, and 1 in 50 or 2% being removed from their homes into out-of-home care. So this is a big public health problem, and it's not something we actually commonly talk about when we think about health. But it's a space we've been doing a lot of work in understanding, I suppose, the very circumstances that can challenge children, families and communities and impact on children's outcomes later in life. And I also just want to acknowledge that Aboriginal children, Torres Strait Islander families are overrepresented in this system. So although they only make up 4% of the population, it's really common to see that they might make up 30% of each of these different types of contact with the system. And there is evidence of that every year that we see in the national AHW child protection reports. So what if we think about that very thing, child protection notifications, in relation to sort of common health outcomes we might see data on more regularly? So here we're actually looking at the prevalence of various health concerns and child protection notifications at age 0 to 14 in 2019-20. So if we just take asthma as an example, we see about 10% of 0 to 14-year-olds will have asthma according to our national reporting, whereas what we're seeing in South Australia is about 25% of children will have been the subject of at least one abuse or neglect allegation by the same age. So this is big, and it's bigger than many of the common health problems we think about. Is it just South Australia's problem? Well, no, actually, it doesn't matter where we look. It's hard to sometimes locate this data, but it looks the same across Australia. And internationally, it's much the same story. It's actually quite challenging for various jurisdictions to access whole of population data like this, but where we can see it, it looks the same. What do we know about children's outcomes? So if we use the Australian Early Development Census, which is a triennially conducted census done on all children starting school across Australia, what we actually see for developmental vulnerability is, if we look here, these are children who've never had child protection contact by age 5. So 21% of those children will be classified as developmentally vulnerable at age 5. And then if we move further through the child protection system to the more serious end, where they've been investigated, substantiated or removed into out-of-home care, you'll see about half of those children will be developmentally vulnerable at age 5. But what if we just focus on this group here that we've spent quite a lot of time thinking about? These are the children who've only ever been notified to the Department for Child Protection once. They have twice the prevalence of developmental vulnerability by the time they turn 5. And these are often referred to as false positives. So, surely not all of these notifications can be real. We often hear the story about the Mars bar in the lunchbox. But for this has implications for how we think as a society about supporting disadvantaged children and families. Then moving on to that second example of causal epidemiology. So understanding what works using administrative data. I'm sure you've all seen this pyramid of sort of the evidence hierarchy before. That's where randomised control trials sit. But of course, we're talking about using observational data. So one of the highest quality, or I suppose highest levels of evidence you can produce is by deploying high quality quasi-experimental studies. So again, this is the great work of Hernan and Robbins, and they've proposed this sort of framework which we can use to emulate randomised control trials and observational data. And we've been doing a bit of that work with some colleagues at Vic Biostat in Melbourne, and hopefully you'll see one of our papers out soon. So really, with this linked data platform, Be Bold, we see quite a lot of process information. So we see a lot of children hit various health services, welfare services, justice services, and you can think about them as processes, and some of them can be thought about as outcomes. But what we don't see a lot of is what we actually do to improve outcomes. So we know we provide a lot of family support services, a lot of, specific, more acute services around homelessness, drug and alcohol, etc. But we don't see that from a system level, and therefore we don't see it in our platform. So we've been working a lot to actually bring this data in, because it's only once we have all three of these that we actually have an intelligent information system that can help contribute to a learning system where we might be looking to improve outcomes for children and families. So we have the Be Bold linked data platform. We enrich that with federal data on top of the South Australian data. You can also connect that up to cohort data with the appropriate consents in place. And of course, we can follow the same children de-identified across these different data sources. And that's really where the descriptive and predictive analytics sits. And then what we're spending a lot of time on now is actually bringing the data in, largely from the NGO sector, some of it's from government-run services, to actually be able to identify, well, when do we actually intervene in children's lives, in families' lives? And then if we can tell who got that service and who didn't get that service, and we can leverage the existing administrative data to make those two groups exchangeable, then we can follow them forward in time and have a look at outcomes that we think those services might have impacted. And of course, down the track, we'd also like to be able to do randomised control trials, which might also take advantage of the existing administrative data as a really cost-effective way to build in long-term follow-up of the participants in these trials. And that's really where testing effects of innovations and understanding what works sits. And that's where we're currently investing a lot of our time. Thank you very much.
That was great. Thank you very much. Please put questions into the Q&A box. People, if you would like to ask Rhiannon a question, I'll take the chair's prerogative and ask the first question. So that's incredible data and, staggering and confronting for me, certainly, I'm sure for many people as well. Can you tell us more about the work you're doing with the NGO sector and helping them to understand and sort of implement policy, the sort of policy implications of your work?
Yeah, so I guess, we started really with this child protection focus. Well, in some ways we fell into it back in 2016 when a big Royal Commission came out. And we really brought a public health perspective to using the data. And so we started to really show, this is, like I said, a public health problem. This is really big. And that narrative hadn't really existed before. So for the NGO and service sector, they've sort of said, wow, this is really bringing what we do with these, disadvantaged families, communities and children into the mainstream. And so what we've actually started working with them on is how can we use what data they collect? How can we actually work with them to even collect better data to start building that learning system I talked about? So often what we've relied on in terms of evaluation in the past is pre-post client surveys, and so that might be nice, but it doesn't really get us very far in understanding, are we actually affecting the outcomes that are the reasons we're investing in these programs in the first place. So ultimately, we're trying to use the linked data to improve the evidence base so we can better understand what we do and what effects it has. And that's, a really big goal of ours, but we're currently working with the Australian Centre for Social Innovation. I was talking to Uniting Communities just yesterday, and we've been working with Relationships Australia to really build up some examples where we can actually go to the sector and we can go to government and say, look, this is an example of what we could do. Why couldn't we do this routinely? And then sort of build that feedback loop so we stop this idea of if something doesn't work, let's defund. But rather, if something doesn't work, let's change our model. What isn't working? And so that's sort of, I guess, the big picture of where we're trying to go. And currently we're just trying to build up some nice examples that we can hold up to say, let's try and build this into something more routine.
Yeah, that sounds great. And I mean, I think your public health framing around the size of the problem and the burdens that are associated with the cases that don't end up through in the substantiated and the out-of-home care is very. I found it very powerful and effective. So I'm sure that that would be the case with decision makers as well.
That in the 30 seconds I could talk about it.
Yes, I did. I even wrote it down.
Yes, because that's exactly right. That is
yeah.
How we think about it.
Yeah, no, I think that's very effective. Okay, well, thank you very much for that presentation. That was outstanding. Our second speaker today is Professor Zoe Jordan. Zoe is the Executive Director of JBI, which was formerly the Joanna Briggs Institute, housed within the Faculty of Health and Medical Sciences at the University of Adelaide. Zoe's research interests are in evidence-based practice, international collaboration and strategic communications in healthcare. So over to you, Zoe.
Thanks, Caroline. I just want to echo both Caroline and Rhiannon and to pay my respects to the Kaurna people and acknowledge their cultural, spiritual, physical and emotional connection to country. Some quick disclosures. I have an affiliation. Obviously, I'm the Executive Director of JBI. We have a major commercial partnership with Walters Kluwer Health, and I'm a member of the JBI Adelaide Grade Centre. I thought I'd better do a quick history. I'm not sure exactly who the audience is, but we were established 25 years ago by Emeritus Professor Alan Pearson with a focus on evidence-based nursing. Now, of course, we're much more multidisciplinary and include address issues related to both medicine and allied health as well. Everybody asks it, so I thought I'd better tell you that we were named after the first matron of Royal Adelaide Hospital, a joint initiative of the hospital and university. At that time, our logo is conceptualised as the pebble of knowledge being dropped into the ocean and the ripple effect of change that can have. We've been part of the university. We moved into the university entirely from SA Health in 2010. We're now part of the Faculty of Health and Medical Sciences. And last year we rebranded to JBI, as Caroline indicated. It's what everybody knows us as, rather than the Joanna Briggs Institute. So interesting alignment with Rhiannon and their group in terms of our vision as being around better evidence for better outcomes and a brighter future. And our mission is to both promote and support both academics and clinicians to use evidence in policy and practice. So just a quick snapshot. Who are we? Well, we're a leading global evidence-based healthcare organisation. We seek to synthesise evidence and support its use in policy and practice, but we also provide education and software to support those activities. We work across 40 countries now in partnership with, I think we've got more than 80 collaboration agreements now with groups across the world, and we all work like probably everybody else on this meeting to improve health outcomes globally. It's really hard to know where to pitch a presentation about JBI, but given that this is sort of to promote collaboration, I thought I'd just do a quick whiz through of our model, because that really covers all of our activity. And then, sort of with the view to, if people are interested in pursuing one of those specifically or more, that they can get in contact, and I hope that you do. So JBI conceptualises evidence-based healthcare as being not only about effectiveness, but about the feasibility, appropriateness and meaningfulness of care provided, but also being cognizant of the context, clinical judgment and patient preference. Really, the start and end point for us is around global health outcomes, and we work really hard to make sure that we're engaging with end users to drive the work that we're doing and drive the focus of the work that we're doing. The green wedge really is representative of our broad view of what constitutes evidence. So yes, as you saw, in very much the same vein as the typical pyramid, we do acknowledge that systematic reviews and research are critical to this endeavour, both quantitative and qualitative research, but where no research evidence exists, then we certainly look to synthesise evidence related to expertise and discourse. Evidence synthesis is probably something that most people are familiar with, particularly around the systematic review piece, but we also do evidence summaries and assist in the development of guidelines as part of this, this synthesis wedge of our model. But of course, it's no good to just synthesise evidence. You need to transfer it somehow into and get it into the hands of those that need it. So we do some of that through our commercial partnership with Wolters Kluwer and consider that to be sort of a strategy for dissemination. But we think it's really important that evidence is integrated into systems and that education is provided, whether it's through CPD, short courses, high degree programs. It's really important to make sure that the clinicians that we're preparing for the future and the clinicians that we have now are really familiar with the process. And the last piece of, or the last wedge of our model relates to implementation, which is really where the rubber hits the road, right? So we really want to make sure that we see that evidence used in policy and practice. But as I said, context is really important. So we need to make sure that there is good context analysis prior to any implementation. Facilitation needs to be, change needs to be actively facilitated, and evaluation is critical to sustainability and making sure that we really are making an impact. Now, around the outside, this is a little bit new to our model. We're reconceptualising things a little bit. Around the outside there, you'll see culture, communication, collaboration and capacity. And historically, we've had those sort of as underpinning things underneath the model, but really more recently, and drawing on some of the business literature around successful organisations and the work of Jim Collins, we've started to think about this model as a bit of a flywheel. So if you imagine a big, heavy flywheel and how you get that flywheel to move, it's about paying consistent attention, pushing it one day at a time, over and over and over again. And that really resonated with us when it comes to evidence-based healthcare. And certainly the discussions that we've been having internally are that there needs to be more discussion about these concepts of culture, of building an evidence-based culture, of having open, transparent communication, of multidisciplinary collaboration. And it's our hope that, if we're paying that kind of attention, that evidence-based healthcare isn't, in addition to everything else that needs to happen in the health system, that it really becomes just part of the everyday. So I did mention that we have a commercial partnership with Wolters Kluwer. I thought I'd just put the product framework up there so that you can see, because it's a little bit different, I guess, in this space, the types of research products that JBI produces from a commercialisation perspective. Our content goes into an EBP database, which is evidence summaries and recommended practices and audit criteria that are really designed for point of care use. We do have a collection. I don't know if collection is really the right word for 2 journals, but we have a couple of journals, one that focuses on publishing systematic reviews and evidence syntheses, and the other one that focuses on evidence implementation. And as I mentioned briefly before, we have 2 pieces of software. JBI Summary is designed to help people conduct systematic reviews, and we now have 10 different methodologies that address different kinds of research evidence and non-research. And JBI PACES is our practical application of clinical evidence system, and it's designed to help clinicians at the point of care to conduct evidence-based audit and feedback and implementation work. I think there are loads of opportunities for collaboration in South Australia. I was so pleased to see that these sessions are going on, and that the idea behind them is that we get to know each other a little better. I guess the fortunate position for JBI is that we are not married to a particular clinical focus. We really are methodologists in relation to synthesis and implementation. So we're really happy to talk to people and give methodological advice around synthesis and implementation. We've had lots of partnerships in putting together research funding applications, and we've been involved in some joint supervision. We have our own HDR program as well. We also run loads of short courses in relation to those two essential sort of areas, I guess, systematic reviews and implementation. We're also home to the Adelaide Grade Centre, and we run grade training and do all sorts of online, mostly online now, conferences, seminars, and things like that. So really keen to hear from people. We do have a range of free resources if anybody's interested in getting online on our website, jbi.global, everything from critical appraisal tools to synthesis and implementation manuals, knowledge bases, things like that, that hopefully are of use and help people to get to know us a bit better and what we do and how we do it. And I forgot to turn my timer on, but hopefully that's around the 8-minute mark, Caroline.
You've done very well. Congratulations. Thank you, Zoe. So please don't forget to put any questions that you'd like to ask of Zoe into the Q&A panel. I'll ask, so perhaps Zoe, while we're waiting to see if anybody else would like to ask a question, perhaps you could talk to us a little bit more about your international collaborations. Yeah, so we partner with groups all over the world, like I said. Most of them are in academic institutions, but we do have a few collaborating entities that are in clinical areas in hospitals. We partner with groups across everywhere from the US to Africa, Asia, and everything in between. We work very closely with groups in low and middle income countries and try to help build resource and capacity in those areas. But in addition to our international collaboration, we also work with what we refer to as cognate groups, or I guess other similar groups with a similar focus. So groups like Cochrane, which I'm sure most people on the call would have heard of, slightly broader focus than Cochrane, but we've been collaborating with them more and more on events and things like World Evidence-Based Healthcare Day, which is coming up in October. So that was an initiative that was really founded by and driven by JBI. So I think it's the 20th of October this year. And we've got a focus this year on evidence, the role of evidence in an infodemic. Very timely. Yeah. So we work with groups like Cochrane and Gin and the Campbell collaboration on things like that, but we also do consultancy work across the government space. We do bits of work with the World Health Organization, Australian Heart Foundation, and all sorts of groups like that in between. So that's fabulous. Thank you. All right. Well, we're almost at time. So time goes quickly, doesn't it? So so I'd like to, so any feedback can be provided. So right now in the Q&A section, or otherwise, please contact ABMC via their website. This excellent presentation and session will be uploaded to the ABMC website. A little promo for next week's session, which is on nutrition with Professor Alison Coates and Dr. Evangeline Mancioris presenting to us on that, with Professor Susan Hillier as chair. So finally, I'd like to thank both Rhiannon and Zoe for their compelling presentations. I enjoyed them very much. I'm sure you did too. And thank you everyone for joining, and we'll see you next week. Okay, bye.